Hello and welcome to Inside Ophthalmology. This is Dr. Amrit welcoming you to part 2 of Binocular Single Vision. I'm pretty sure that you are one step stronger and sharper now to take this another strabismus class, isn't it? In our previous video, we talked about the fundamentals and core concepts of binocular single vision, and today we shall be talking basically about the various sensory adaptations that we see. Okay, so now let us get started. First, we shall be talking about the retinal rivalry. Okay, so the phenomena of retinal rivalry is actually basic to binocular single vision. So, as threatening as this looks, this is basically a normal binocular vision response. So, if anyone has a normal binocular single vision, they will have retinal rivalry. Now, the question is, what is retinal rivalry? So, when dissimilar contours are presented to corresponding retinal areas. Okay, so in our previous video I told you what is meant by the corresponding retinal points. So if you present two dissimilar contours, for example here you can see that to one eye we are projecting a picture with the oblique lines oriented in one direction, and to the other eye we are actually projecting the image with oblique lines oriented in another direction, right? So definitely these two stimuli are basically non-fusible. That means it is almost impossible for the brain to fuse these images. So when such dissimilar contours or images are presented to corresponding retinal areas of the two eyes, fusion will be impossible, and instead what you see is retinal rivalry. So instead of fusing the images into one single image, the brain is going to interpret it as a mosaic of the two images. Okay, now the question is, why is this retinal rivalry seen? Now the retinal rivalry phenomenon basically has been explained in neurophysiological terms by the presence of two separate channels. That means we have a right channel, okay, that carries the information from the right eye, and then we have a left channel which carries the information from the left eye, and that is how these two channels basically are also competing for access to the visual cortex. But if the image presented to the right and the left eye is similar, then a third channel, which is a binocular channel, will get activated and they will have an easy access to the brain. And this, however, happens only if the input is fusible. That means the two images are same, right? And if the input is not fusible, then you are going to see what is retinal rivalry. What I mean to say is that you will have this competitive interaction between the two visual channels, right? Now, as a matter of fact, this competitive interactions occurs not only in the visual cortex, but it actually continues at several afferent levels of the visual pathway, right from the retina to the visual cortex, right? Now, because of this competition and inhibition of one another, only the fragment of the image will be seen by each a fragment of the image seen of each eye will be transmitted to the striate cortex in case of a non-fusible binocular input. So I hope that is clear, right? So what did we see in our example? In the left eye, the lines are basically traveling from the left side above to right side downwards. Whereas in the right eye, what is the right eye seeing? The right eye seeing a pattern in which the lines are basically traveling from right above to left downwards, right? So because these images are not fusible images, instead what the eye is going to see, what the brain is going to interpret it as this mosaic of different lines which are traveling in different directions. So that is what is meant by retinal rivalry, right? And actually speaking, this retinal rivalry is something good. It is an indicator that there is binocular single vision present. Okay, now if there is constant foveal suppression of one eye, that means if the patient is able to suppress the deviated eye or any eye for that matter, what does it mean? It means that one eye is dominant over the other, right? And this sensory dominance is basically going to lead to abolishment of your retinal rivalry, and instead the patient is going to see just one of the stimulus. So for example, if the left eye was dominant, only the right eye will be seen, and if the right eye is dominant, only the left pattern will be seen. And mind you, here I'm not talking about the normal dominance that we physiologically have. I'm talking about those really complete sensory dominance, which can actually lead to complete suppression of the other eye, leading to abolishment of the retinal rivalry. As a matter of fact, retinal rivalry return after strabismus surgery is actually a very good sign. It is a requisite for re-establishment of binocular single vision. So that was a clinical nugget regarding the retinal rivalry, right? So I hope you are with me. Okay, so now moving on. So what happens is that when a manifest deviation of the visual axis of the two eyes is present, okay, either there is esotropia, exo, hyper or hypo or any of the torsional deficits, what happens is that as the deviation develops, the image of the objects in the field are also shifted on the retinas relative to each other. Okay, the larger is the shift, the greater is the deviation. That means the squint is basically presenting an abnormal motor situation by shifting the images on the retina, and the brain has to deal with that abnormal motor situation by doing certain sensory adaptations, right? And this is what we are going to basically study. Okay, so brain's sensory adaptations are actually a nature's way out of trouble for the patient, who by these mechanisms is actually going to gain some comfortable, remember, comfortable single monocular vision or an anomalous form of binocular cooperation. So by doing this sensory adaptation, the patient will not be able to get the binocular single vision back, but he can deal with the problems that arise because of the absence of binocular single vision. Okay, by doing these visual adaptations or sensory adaptation, instead the patient is going to get comfortable single monocular vision or an anomalous form of binocular vision, right? So you're going to understand this as we move ahead with this lecture, right? So these sensory adaptations basically can occur either in a visually mature system, so what I mean to say is in adults, or the sensory adaptations in a visually immature system, right? These adaptations are different, and that is why we are going to actually classify them into these two categories broadly. Let us talk about the adaptations that happen in a visually mature system. So what do I mean by this term? So basically these are the patients which were normal, or they had normal retinal correspondence or binocular single vision up to the age of 9 to 10 years, right? So this 9 to 10 years is actually a sensitive period wherein the brain is actually pliable and various other adaptations can take place, okay, which we are going to talk about later. But these patients were actually normal up to the age of 9 to 10 years. They enjoyed binocular single vision, and then they got an insult to the visual system which threatened their binocular single vision after the age of 9 to 10 years, right? So these patients are known to have a visually mature system, and the sensory adaptations which happen in them can basically be of three types. Number one, because they had a normal binocular single vision up to that level. So initially, when they get an insult, they will definitely experience retinal rivalry. Now, that retinal rivalry can again lead to further problems, and they can have either confusion or they can have diplopia. Okay, so the basic defense mechanisms that will develop in these patients, or the sensory changes which happen in these visually mature systems, are confusion and diplopia. First is confusion. So let us try to understand this. What is meant by confusion? Now, I hope you know what is meant by corresponding retinal points, right? We know that the fovea of two eyes are actually corresponding to each other, right? So, whenever two superimposed but dissimilar images of two different objects obviously are projected onto the fovea, which are corresponding retinal points of the two eyes, then you get confusion. Okay, so let us see what it is. For example, here you can see that this eye actually is slightly rotated inwards, right? And obviously the fovea of the left eye will be corresponding to the fovea of the right eye. Now, because of the deviation of the left eye, what is happening? This apple is obviously falling on the fovea of the right eye. However, something else is being projected on the fovea of the left eye, and in this case, it's a tree. It's a small cartoon tree, right? Now, since the fovea of two eyes are actually corresponding and they have a similar visual direction, Remember, I explained to you what is meant by visual direction in my previous video. Okay, so these fovea, since they have visual direction which is similar because of their being corresponding, what will happen? The brain is going to localize them into the same space in the into the same spot in the visual space, and therefore they will be seen as overlapping images like this, and there will be confusion. Right, so this is what is meant by confusion. When two dissimilar objects are falling on two corresponding points of the two eyes because of a presence of deviation, this is known as confusion, right? And it is seen in the visually mature system. Now, the thing is that confusion is not often reported voluntarily, but when patients do notice this overlap of different foveal images, it is really distressing. Okay, now I would like to actually clarify one point here. Since I'm explaining this to you under the visually mature system, it doesn't mean that this is not seen in children. It is just that the kids or the visually immature system under the age of 9 or 10 years, it's just that they have further capabilities due to their cortical immaturity or visual immaturity to deal with these problems further, right? So kids can actually deal with confusion and diplopia further, right? And that is why I have put confusion and diplopia under the visually mature problems, right? So what kids can do is, what a kid will do is, for example, if they encounter confusion, they will just suppress the fovea of the deviated eye. For example, here the deviated eye is a left eye. So what they're going to do is they're going to suppress the fovea of the left eye. So this image is going to disappear, and they will just have this single image being formed by the right eye, and therefore there will be no confusion. But this doesn't happen in case of adults. So this is what I want to tell you. Having understood that, we can now understand a clinical nugget regarding this confusion, right? So it's difficult to perceive confusion, but patients who actually have a tunnel vision, like retinitis pigmentosa and those with advanced glaucoma, what happens is that they have a really constricted field of vision, and they really don't have a choice but to project the images right onto the central area of their retina or the fovea, and moreover they can't even suppress that fovea in that eye, and therefore these are the patients who will actually experience confusion practically following a deviation. So that was your clinical nugget. The next mechanism or the next sensory adaptation that occurs is diplopia. This is pretty common compared to your confusion, right? So what exactly happens in diplopia? Before that, let us revise. Fovea of two eyes are basically corresponding to each other, and the points which are present on the temporal part of one retina will be corresponding to the points located on the nasal part of the other retina. The points located on the nasal part of one retina will be corresponding to the points located on the temporal half of the other retina. Now, if a same object is projected or falling on non-corresponding points, and why will that happen? That will happen because of a deviation, of course, right? So simultaneous appreciation of two images of the same object on two non-corresponding points will lead to diplopia. Okay, now let us take this example again. Now this was the fovea of the left eye, this was the fovea of the right eye, and this is your image, or this is your object of interest, which is an apple. Right, now obviously it is going to fall on the fovea of the right eye, but the left eye actually is slightly deviated towards inside, and therefore the object is falling on the nasal part of the left eye, and therefore the image is also going to form somewhere here, leading to two different images in the visual space of the same object, because the object is falling on the non-corresponding points because of deviation, and this leads to double trouble, double vision, or diplopia. Okay, so I hope that is clear. Now in the first picture you can observe that the left eye is basically deviated inwards, and in the second picture the left eye is deviated outwards. That means there is an exodeviation. Now what happens is that the object, which is an apple, is falling on the fovea of the right eye, and therefore it is going to be localized correctly. However, you can see that in the left eye the object is not falling on the fovea, which is situated here. Instead it is falling somewhere on the nasal retina, and therefore when the image actually is falling on when the object is falling on the nasal retina, the image will be in the temporal field, and therefore you see that the image of the left eye is present on the left side and the image of the right eye is falling on the right side, leading to uncrossed diplopia. Whereas it is totally opposite to what you see in cross diplopia. In exodeviation, the object is going to be projected now on the temporal half of the retina, right? So this is the fovea, this is nasal retina, this is temporal retina. The object is falling on the temporal retina and therefore the image is now falling where? It is falling on the other side, on the nasal hemifield of that eye, and therefore you can see that the image of the left eye is instead present on the right side and the image of the right eye is present on the left side, and therefore in exodeviation you have cross diplopia. If you can't remember the mechanism, at least remember that exotropia has an X in it, and therefore in exotropia you see crossed diplopia, right? So with this we finished three sensory mechanisms which are seen in a visually mature system: retinal rivalry, confusion, and diplopia. So basically to summarize what exactly happened because of the deviation, what is happening? Either the two foveas are going to receive two different images, and since they have similar visual direction, what is going to happen? There will be overlapping of the images leading to confusion. Or there will be similar object which is being projected on two non-corresponding points, and that is leading to two double images leading to double vision, right? So either you can have diplopia or you can have confusion, and the only way to actually prevent them is by carrying out a suppression. But since we are dealing with a visually mature system, the visually mature system or adults basically do not have this capability of suppression, and therefore they have to deal with these two situations. Okay, however, kids, what they will do is, in order to prevent confusion, they are going to suppress one fovea, which is called foveal suppression, leading to a monocular vision but no confusion. Or to suppress diplopia, they are going to actually suppress this peripheral point which is receiving the input along with the fovea, and this is called a peripheral suppression, right? So either of the two can actually happen in a visually immature system. Okay, we'll discuss about this more. So honestly speaking, these confusion and diplopia are not abnormal. So why do I say that? So they're basically physiologically correct sensory responses, right? So this is what I mean to say. Physiologically, whatever is happening is right. They must occur in every patient who has adequate vision in each eye, but in whom an acute relative deviation of the visual axis has actually developed, right? So anyone who has a binocular single vision, if they actually if they develop an acute deviation, they are going to actually have this diplopia, confusion, and that basically tells you that they actually enjoyed normal binocular single vision before the age of 9 to 10 years. Now, let us talk about the sensory adaptations that are seen in a visually immature system. So, what do I mean by visually immature system? So, basically, when binocularity is disrupted in the first few weeks of life, especially before 8 to 10 years, then the visual system is basically immature, and the sensory adaptations or the defense mechanism of a visually immature system are basically suppression, anomalous retinal correspondence, amblyopia, and a monofixation syndrome. So let us now try to understand all of these one by one. The first that we will talk about is the suppression. So what happens is that in a child or in the age group of less than 8 to 10 years of age, whenever there is a large angle of deviation which is of constant nature, then the brain will basically suppress one of the image which is coming from the eye that is deviated. Okay, so suppression is nothing but, as the name suggests, it is actually an active central inhibition. That means the brain is basically inhibiting the image. So suppression is an active central inhibition of the disparate and confusing images which are originating from the retina of a deviated eye. And for suppression to develop, the visual system basically should be immature. So it's very, very important. So if you would remember, we discussed about confusion and diplopia occurring in a visual mature system as well. Similarly, in a visually immature system also it will develop, just that they have the faculty or the facility to basically deal with it by suppressing appropriate points on the retina. So if they are suppressing the fovea of the deviated eye, for example, here the fovea of the left eye, then they are basically dealing with the confusion, and this is known as central suppression when the fovea is basically suppressed by the brain, right? Whereas when any point other than the fovea is suppressed, that is known as the peripheral suppression of the deviated eye. And this peripheral suppression is basically done in order to prevent diplopia. So here, this point, which is giving a double image of the apple, okay, if we suppress this peripheral point, that is peripheral suppression, then the patient will basically see only one single apple, right? So this is called suppression. Central suppression where the fovea is suppressed, and peripheral suppression when other points other than the fovea are basically suppressed. Now, as a matter of fact, whenever there is deviation, there is going to be diplopia and confusion together. Okay, although we talk about these terms separately, they're actually not very well segregated. Everything can everything can actually coexist, and different sensory adaptations can actually be present in one single eye. Similarly, confusion and diplopia can also be present together, and therefore usually as an adaptation in a visually immature system you will find two scotomas. One scotoma will be present in the foveal region, which is basically dealing with the confusing images, whereas the other scotoma, which is in the periphery, dealing with the double image. And this is how you see two scotomas. Now, however, if the angle of deviation is too large, then what happens is that these two scotomas basically will coalesce together. Apart from that, clinically, the suppression can actually be divided into a non-alternating suppression or an alternating suppression. Now, what is meant by non-alternating suppression? In non-alternating suppression, there's a clear-cut dominance of one eye, and that eye is going to predominate over the image of the deviating eye. And when there is this predominance of one eye, it usually leads to dense suppression, and that dense suppression ultimately causes amblyopia. Okay, that is decreased visual acuity. Whereas sometimes there will be no dominance between the two eyes, and the two eyes actually keep on switching their fixation alternatively, and therefore the suppression also keeps on switching between two eyes, and this is known as alternative suppression. Okay, so as you can see over here, this is an example of alternative suppression. You can see that the fovea over here is basically fixating on the hut, and the fovea of the right eye is fixating on the tree, right? Now, if both of them were acting together, there will be confusion. However, as a defense mechanism, what brain does is that when the left eye is fixating, which is fixating on the hut or the house over here, the image which is coming from the right eye, from the right fovea, will basically be suppressed. Okay, so what I mean to say is when left eye is fixating, the right eye is basically suppressed, and therefore what you are seeing is the image from the left eye, that is the hut. Whereas when the right eye now starts fixating, it is fixating on the tree, and therefore you see only the tree, because the hut which is formed on the left eye is going to be suppressed because of foveal suppression. Okay, so this is known as alternative suppression. This is usually seen in alternative deviations like alternative exotropia, right? Now, apart from that, another term is facultative suppression. Now, facultative suppression basically means that here the suppression is going to be present only when the eyes are in the deviated state. Now, this sometimes happen in deviations which are of intermittent nature. That means these deviations come and go. And as the deviations come and go, the suppression also comes and go. Okay, so the suppression is called facultative suppression, and it only occurs when the eyes are deviated. Okay, so it is seen in intermittent exotropia. So what happens is that when the eyes are not deviated, the patient is actually going to enjoy a good amount of stereopsis and binocular single vision. Apart from that, another term is constant suppression. As the name suggests, this will be present irrespective of whether the eyes are aligned or they are deviated. Now, an important clinical nugget over here is that once constant suppression develops, it will persist throughout the life. So, why is it important? For example, if a patient who had developed suppression during the childhood, that patient is obviously enjoying a monocular vision. That means they don't really have that double vision or confusion, right? Now, if such a patient loses that ability to suppress during adulthood, that is after the age of say 8 to 10 years, that's what I mean to say here, either because of a head trauma or because of some ill-advised or thwarted treatment or even after surgery, then that double vision basically is going to return. And this double vision is because of the disturbed suppression or loss of the suppression, and this suppression actually can never be regained later, and double vision is going to prevail in such patients, right? So remember that the ability to develop suppression is present only in the visual immature system, and even if it is developed and it is disturbed later on in the life, then it is very difficult to gain it back. Now, here it will be very important point to differentiate between suppression and voluntarily ignoring a distressing image. Now, this actually happens in physiological diplopia. So, in our previous video, we talked about how you experience physiological diplopia, and that is actually based on the concept of Panam's fusional area and horopter. So basically over there, we are psychologically ignoring one distressing image, right? So ignoring the image is totally different from suppression. When you're ignoring the image, it is happening psychologically and it is a normal part of binocular vision. However, suppression is an active intrinsic inhibition of the afferent visual information. So I hope that is clear. So we finished discussing suppression, and next let us talk about the abnormal retinal correspondence. Now in my previous video also I told you in detail what is meant by abnormal retinal correspondence. So basically we know that the fovea corresponds with the fovea of the other eye, and other points also have their respective corresponding points. But sometimes the fovea actually develops correspondence, which is a common visual direction, with some other point on the retina. That means an extrafoveal area of the other eye. And when such an abnormal correspondence occurs, that is known as the abnormal retinal correspondence. And this abnormal retinal correspondence is usually seen when the angle of squint is very, very small and the extrafoveal point is located somewhere close to the fovea. So such patients, despite having an abnormal retinal correspondence, they are actually enjoying binocular single vision, and this is their way of dealing with the double vision or confusion, right? So I hope that is clear. Before we understand the types of abnormal retinal correspondence, it is very important to understand what is meant by the objective angle and the subjective angle. The objective angle is basically the motor deviation or the angle of squint that is basically seen from outside, right? So over here we can see that the right eye is deviated inside or inwards, and therefore the objective angle is what you're going to measure with your prisms, right? So suppose the objective angle here is about 20 prism diopters, okay? Now, the rays from this object, which is an apple over here, is actually falling on this point on the retina, which is situated on the nasal retina, right? Now, let us assume that the fovea of the other eye is actually developing the correspondence with this point on which the rays from the object are being projected, right? And that is what exactly is meant by the abnormal retinal correspondence. Now, the distance between this point and the fovea of the deviated eye is known as the subjective angle, right? So the subjective angle is a sensory deviation, or how far off the extrafoveal retinal point is from the actual fovea. So basically over here we know that this apple is being projected on this point here instead of being focused on the fovea. Now, if the fovea were to develop correspondence exactly with this point over here, and that means that it is a best kind of adaptation and this fovea has developed perfect correspondence, and therefore this correspondence is called harmonious correspondence or harmonious abnormal retinal correspondence. Okay, the deviation here is fully neutralized sensorially, that is the shift of the visual direction has fully been offset by the amount of deviation, right? And this perfectly developed abnormal retinal correspondence is called harmonious abnormal retinal correspondence. And here the objective angle will be equal to the subjective angle. Okay, so this is what I mean to say. Okay, so in harmonious abnormal retinal correspondence, the fovea is exactly going to develop correspondence with the exact point where your object is being imaged on the retina, and therefore it is called the harmonious abnormal retinal correspondence. However, if the fovea develops correspondence with another point on the retina which is closer to that abnormal point but not exactly that point, that means there is still some amount of correction that the fovea needs to do, right? Some amount of work that the fovea or the eye needs to do, right? So that is called unharmonious abnormal retinal correspondence. So what I mean to say is, if the amount of shift of the visual direction does not fully compensate for the deviation, the adaptation is not complete, and this is what is meant by unharmonious abnormal retinal correspondence. So if the objective angle, for example, in this case, let's say is about 8 prism diopter, if this was a harmonious abnormal retinal correspondence, this angle would also be a 8 prism diopter. But in an unharmonious abnormal retinal correspondence, the fovea is going to develop correspondence within another point which is close to the intended point and say here, and therefore your subjective angle will be say just 5 prism diopter. Okay, so your subjective angle is not equal to your objective angle in case of unharmonious abnormal retinal correspondence, right? So obviously harmonious abnormal retinal correspondence is going to give a better vision to a patient compared to the unharmonious variety. So I hope that is clear, right? Now with this, now let us discuss about an important clinical nugget. Now we know that suppose this is the left eye fovea and this is the right eye fovea, and the right eye is deviated inwards, right? So here we have another point, okay, at which the object is being projected, right? And for an ARC to develop, what will happen? The fovea of the left eye is going to develop correspondence with this point. Now let us say this patient has a perfectly normal harmonious abnormal retinal correspondence. That means there is no double vision in this patient because the fovea is corresponding to this point over here in the right eye. Understood? Now, what if we actually introduce a prism in front of the deviated eye here? And since the eye is isodeviated, we have introduced basically a base out prism, the apex in the direction of the deviation. Okay. Now what is going to happen? The rays, after they pass through the prism, they basically bend towards the base of the prism. And now what will happen is that these rays are going to go and focus on the fovea of the right eye. Now what will happen? The fovea of the right eye is not corresponding to the fovea of the left eye here because the patient has abnormal retinal correspondence. Okay, and therefore what will happen? The visual direction of the two foveas is different, and therefore you will have double vision now. So this patient, after the introduction of a prism, is going to complain of diplopia of double vision, and therefore such a diplopia which occurs after the introduction of prism or after correction in a patient with ARC is known as paradoxical diplopia. Okay, so where do you see paradoxical diplopia? You see it in a patient with abnormal retinal correspondence. Now, important point regarding this is that this diplopia can actually persist after surgery for about 4 to 6 weeks, and then it will disappear, and therefore an appropriate counseling for the patient is very, very important preoperatively. Let's talk about another important clinical nugget. Now, many of you actually get confused between abnormal retinal correspondence and eccentric fixation, saying that here also we have an eccentric point which is taking the position of the fovea. However, there is a difference between abnormal retinal correspondence and eccentric fixation. In abnormal retinal correspondence, whatever correspondence is being developed between the fovea and the extrafoveal point is basically under binocular conditions. That means if you are going to cover the normal eye, the extrafoveal element is going to lose that advantage that it has along with the fovea of the other eye. And now the fovea of the deviated eye here is going to again takes its predominance, and the eye is going to move to the normal position. Therefore, ARC only works under binocular condition. It's a binocular condition. It doesn't work under monocular condition, and that is how you can actually even detect ARC. Apart from that, if you talk about eccentric fixation, on the contrary, it can be seen both in uniocular or binocular condition. So here, when you introduce your cover in front of the normal eye, even then this eccentrically fixating eye is not going to move back to the fovea, because for most of the reasons, in most of the cases, in eccentric fixation, the fovea is abnormal, and that has actually forced another point to take the role of fovea. That is what happens actually in eccentric fixations, right? So in eccentric fixation, when you actually cover the normal eye, the deviating eye is not going to come to its normal position. Okay, so eccentric fixation, it can be seen in uniocular as well as binocular conditions. So now moving ahead to the another mechanism, and that is monofixation syndrome. Okay, so this monofixation syndrome, you should remember that it is quite similar to suppression. Okay, this is nothing but central suppression or foveal suppression that is seen in kids with small angle deviation less than 10 prism diopter. Okay, so in these cases, what happens is that sometimes when you have a small angle strabismus of less than 10 prism diopters, or you have some minor problems like anisometropia or unilateral astigmatism, and sometimes even unilateral media opacity, what will happen? The child will actually develop this central scotoma. It's a very small central scotoma that develops because of suppression. So that is why I told you that suppression is very similar. Suppression actually has a role in monofixation syndrome as well. So here, because of that small angle strabismus, and in order to deal with the problems that can arise because of that small deviation, obviously by now you should know what are the problems arising because of deviation, right? So here what will happen is the kid is going to develop this small central scotoma retaining the peripheral fusion. Okay, and this is what is meant by monofixation syndrome. So in monofixation syndrome, you have unilateral facultative central foveal suppression scotoma with a binocular peripheral fusion. Okay, apart from that, they will have very small angle of squint, and when you do your alternate cover test, you might actually detect variable heterophoria as well. Now, obviously, because there is a central scotoma, the stereo vision, however, is not going to be good in these cases, and amblyopia also will be variable. But usually, you see a mild amblyopia in these cases. So there is a clinical nugget associated with monofixation syndrome. Okay. Now it has been reported that patients who have congenital esotropia, that is an inward deviation of the eye, these kids, when they are actually operated or when they are corrected surgically, they have a tendency to develop this monofixation syndrome after surgery. As a matter of fact, what is important here is that these patients who actually develop this monofixation syndrome, they are twice as likely to maintain long-term alignment as a result of this sensory adaptation. So that becomes a very important point, that monofixation syndrome, which is occurring after surgical correction in an esotropic patient, will become a favorable surgical result for the surgeon, because these patients are actually now going to they are going to basically show long-term alignment. Okay. So with this, we finish the monofixation syndrome. Ultimately, we have amblyopia, which is actually speaking of a sort of is basically a type of very dense suppression, right? So we already have video on amblyopia. We have two videos on the channel. So to understand amblyopia in greater detail, you can actually visit them. So that was about the sensory adaptation. I hope that made sense to you. I hope it was useful. Kindly let me know in the comment section what you liked about the video and also your queries. I know we all struggle with strabismus, and in understanding strabismus, the information is variable, the teaching methods are variable. Do let me know in the comment section how you actually struggle with squint, or even if you actually love squint, you can tell me in the comment section. And so that was all about it. I hope you enjoyed it. Thank you and have a nice day. If you liked our content, make sure to subscribe to our YouTube channel. Also, you can actually join our YouTube memberships, and I often get a question as to how do I join the membership. So let me demonstrate that to you now. order to become a member of Insight Ophthalmology, first you need to watch any video of Insight Ophthalmology. For example, right now I'm watching this video on mastering iris anatomy. So here below the video, you will see there are two buttons. One is a join button and one is subscribe button. So make sure you're subscribed to the channels. Okay, so this is what happens when you subscribe to the channel. And after that, you can see that on the left hand side, there's a join button. So using this join button, you can actually join the memberships. So once you click on the button, you will be able to see that there are 3 levels of memberships which are available, and their perks are actually depicted on the right hand side of the dialog box. So you can choose the membership which is best fit for you, and once you actually choose it, you can click on the join button and then you can do the purchase according to the method which is best fit for you, right? So that's how you actually join these memberships. And often I get a question that people are not able to join memberships, they're not able to see join button over here. So the reason could be either you're not logged in, so make sure that you are logged in into your YouTube account. And the second thing that you need to make sure is that sometimes the YouTube memberships might not be available in your country because of some security reasons and because of some private policies of YouTube and the government in your country, right? So in those cases, I also cannot help you. I really apologize that I'm not able to help you in that case, right? And for the rest of you who are lucky to see this join button, you can go ahead and click on it. And that's all. I hope it was useful. Thank you and have a nice day.